Good evening, everyone, and once again, thank you so much for having me, ma'am. It's always a pleasure to be amongst all of you, and it's always a pleasure to share the knowledge. I think it's a great idea to have a nephrologist, cardiologist, and endocrinologist on the same platform to talk about SGLT2, because there are often times where the indication for the same often coincides, and a lot of the times, when one of the specialty doesn't want to prescribe it, the other specialty does. So often it is, in fact, recently I got a call from cardiology saying that, oh mane, SGLT2 kyak to fit karit de, right? And that was, often the thing, right? So SGLT2 inhibitors, I think it's a wonder drug, without a doubt. And while we always say that, this is a very, it's an excellent molecule, it's also very important that we understand that, this famous quote that with great power comes great responsibility, right? So SGLT2 inhibitors, DPP4 inhibitors, you can give it to anybody, right? Old, young, except for somebody who has some known, dermatological contraindication. You can probably prescribe it easily without missing a beat. SGLT2 inhibitors, not so much, right? You have to think the right patient. Often, if you do not give it to the right patient, you end up having then to backtrack or change the molecule. And changing SGLT2 is also very difficult, as you'll realize, right? Sometimes, you have a severe hyperglycemia that happens when you stop SGLT2. So it's a very important molecule, but it's also very important to know when not to prescribe, okay? So what I'm going to do is I'm going to go through a series of, the other talks. I'm very unfortunately not aware what exactly you're going to talk about, but mine will definitely be like a summary of all the conditions where you should not give SGLT2, right? There are, of course, caveats to that. There are certain things which we often perceive as a contraindication, probably is not a contraindication. So that also I'll brief you, right, in those things. Now, one place where you definitely should not prescribe SGLT2 is a patient with type 1 diabetes / I have said suspected type 1 diabetes, because not always, it's very apparent that it's type 1. Remember, common misconception is that type 1 only occurs in children. Not necessarily. Type 1 can occur technically at any age. Even elderly type 1s also we have seen, right? New onset also. So when you have a patient with severe hyperglycemia suddenly appearing out of nowhere, ketosis, right? Patient requiring insulin, some of them you would have admitted your patients as well. When you're 100% sure it's type 1, 100% don't prescribe SGLT2 because it's contraindicated, right? It's amongst the list of contraindication. But when you are not sure or cannot easily classify the patient surely as type 2, and you are suspecting type 1 or you are not sure where it lands, again, be careful in prescribing SGLT2. Having said that, there is a caveat here also, right? Someday you will find maybe 1 or 2 odd of my patients where I have written specifically type 1 and then also prescribe SGLT2, which is rare, right? I don't recommend doing it, but there are certain patients with type 1 diabetes, well insulinized, on insulin, taking it properly, compliant, right, has some other reason why you can prescribe an SGLT2, other benefit of that, for example, maybe a renal involvement, right, and you know that this patient is going to follow up with you regularly, you know that the patient understands the risk involved of giving this medication, and you also know that there is definite benefit of this, right, in that very small sliver of a subset with adult type 1 diabetes. There are a few patients of mine where we have prescribed SGLT2 with dramatic results. I think, we underestimate we definitely have the benefit in type 2, but in this type 1 small subset where you actually can give, the weight comes down, the proteinuria literally disappears. Some of these patients, there's good amount of weight loss. Of course, these days we see type 1 also over obese very commonly, right? So much so that, very interestingly, I had this one type 1 of mine whom I had earlier prescribed an SGLT2 and then discontinued it because she had some injury and then she was admitted in the hospital and then I discontinued. Said, okay, fine, we'll just put you on insulin for now. Today she insisted that why are we not restarting that SGLT2, because, I'm gaining weight again, right? You can see the proteinuria is coming back. Why not, So my sugars were much more stable before. So type 1, it's technically a contraindication. There will be a few subsets where probably you can give, but it's a very small thing, and unless you have experience in this, and you are very sure that the patient is closely going to follow up, only then, otherwise no, right? So any patient with type 1, you are putting yourself and the patient at risk by doing that, right? But then comes the gray area of a ketosis-prone type 2 diabetes. Right now, I remember when I was a medicine resident, this is what was our protocol. Patient comes with sugar of 300, 400 in emergency, right? This was what our seniors had taught us. Check ketones. Ketones are positive, admit. Ketones are negative, call him to OPD tomorrow. That was the standard protocol which we used to follow, right? Patient has blood sugar of, well, somewhere less than 200, send the patient home, right? That is what we used to do in ER, right? At a busy government hospital ER, you don't have time to think. And a lot of them were adults, some of them were adolescents, some of them were, obviously more than 12 years of age, but children. But all these cases, now when I became an endocrinologist, I realized what really happened to those people, right? I mean, we put them on insulin, and then we assume that they were type 1, but were they really type 1, right? So there's an entity called ketosis-prone type 2. Very interestingly, it is very common in India, right? You don't see too much. You now, of course, have chapters on ketosis-prone type 2, and you have even Up to Date has a chapter on ketosis-prone type 2. There's actually a classification now for this condition, but it's actually not uncommon in Indian patients. You'll see a lot of Indian adult patients. What is ketosis-prone type 2? These are patients who actually have some residual insulin producing capacity, but they initially present in a more fulminant way, present in a more with ketosis, right? And then eventually you give them insulin, their blood sugars improve, the glucotoxicity goes down, and these patients, the ketosis goes away, and their insulin requirement also goes away, and then eventually they can be put on oral antidiabetics also. And we see a lot of patients like this. In my practice, I've seen a lot of them, right? Specifically label that as ketosis-prone type 2, just to tell myself that this is a vulnerable patient. And these patients, be very careful before you prescribe SGLT2. Because we had again burnt our fingers at these type of patients, that you treated the patient became better, you are now sure it's type 2, you have done C-peptides, you have done GAD antibody which is negative, you have done all kinds of markers what you needed to do to assure yourself that it's type 2. And you found that maybe this patient is a candidate for SGLT2, and they gave SGLT2 and the patient ended up with ketosis again, right? So unless you are very sure, again like that subset of type 1 where you are very sure, these patients again be very careful before you give them SGLT2, right? So you have any patient labeled as a ketosis-prone type 2, or patient has a history of ketosis in the past, right? Obviously, not everybody will put that label, right? So, but if the patient gives a history that I was actually admitted for ketoacidosis, or admitted for ketosis in the hospital, right? At some point of time in my life, I think you'd be very careful of prescribing SGLT2 to them. And so that's one group of patient you will be a little bit careful, okay? So this is second patient, right? The concern with these two cases is a condition called SAPCA, which is basically euglycemic ketoacidosis. There is a specific term. It's called SGLT2 inhibitor associated perioperative, a lot of times because it's perioperative, ketoacidosis, or SAPCA, right? This is, in fact, now there's a terminology for this, right? With the very fact that it's not uncommon at all, right? Now, why is this a problem, right? And why does euglycemic ketoacidosis typically happen in these patients, right? Trust me, we have seen a lot of patients. The problem with euglycemic ketoacidosis in a type 1 or a ketosis-prone type 2 or certain perioperative patients is because a lot of the time this goes unrecognized, right? Sometimes post-operatively the patient continues to have acidosis, the anesthetist is not sure, the physician is not sure, the surgeon is not sure what's really happening. Patient is on a ventilator, it's difficult in weaning off the patient of the ventilator. There are electrolyte imbalances which cannot be explained, right? So this is and very commonly seen in cardiac units, right? Cardiothoracic surgery. I think I remember 4 or 5 years back, we used to have at least once a week we used to have one documented case of SAPCA, right, from cardiothoracic surgery, right? Now, of course, it's become less common because now the cardiac anesthetist is now aware that this is something which is possible, right? So that is what typically happens, right, especially in a perioperative period, right? And if you see the number of cases reported of euglycemic ketoacidosis in literature, 2014 to 2021, you can see the numbers increasing, right? And now, of course, it will plateau because now it's become so common, nobody's going to publish something like that because it's now a well-known entity, right? So what exactly is euglycemic ketoacidosis? Why you should recognize this and why it goes unrecognized? The random sugar, this is definition, random sugar is less than 250, the pH is less than 7.3, the bicarbonate is less than 15, and very importantly, and this is one test, right? I'll show you the guidelines on this or show the literature on this. Very useful test is anion gap, right? So anion gap you can do by your ABG, but you can also do VBG, right? Venous blood class. Very simple, right? Easy to calculate. In fact, anion gap will come in your, that printout that comes out, right? So you will have the anion gap. It's a very useful test. In fact, anion gap is also very useful. Again, we have residents here, right? Anion gap is very useful in patients with, when you want to see resolution of diabetic ketoacidosis also. Very useful, right? So anion gap more than 12. This is the definition of euglycemic ketoacidosis. Now, problem is the sugars are often less than 250. So sometimes these patients come in emergency with respiratory distress, right? And in emergency, they do a random sugar, it's 180, right? And then they do a ABG, where they have documented metabolic acidosis, high anion gap metabolic acidosis. Now, they can't do 1 + 1. It's very difficult in emergency to really make that thing, that this is euglycemic ketoacidosis, right? So, patient gets admitted, and then after a few days, you realize, acha, okay, this was the problem, right? So, that is sometimes, what happens. Again, in emergency, sometimes patients come, you ask them which medications you are taking, right? Now, there are so many companies making dapagliflozin that nobody really knows, right? That we are also confused, whether this has dapagliflozin or not, right? So often, you have this kind of problems, right? So beta hydroxybutyrate is another test. Of course, now we have it in our hospital, but now we also have this, the handheld ketone meters also available in India, right? So you can use beta hydroxybutyrate and the value more than 2 millimoles per liter, right? That is, if you are using your lab, it's 20 milligram per deciliter. If it's more than that, it's euglycemic ketoacidosis. Now, why do these patients develop euglycemic ketoacidosis? It's a very interesting theory. So there are three things which happen, right? One is the patient has some sort of a physiological stress, right? There is always an element of relative insulin deficiency, and then there is reduced insulin release, right? There is deficiency plus the release is also impaired, right? Now, the problem is, remember this, and again, students need to understand this. The ketosis only happens generally when you have low insulin and high amount of glucagon, right? When you have this imbalance, less insulin, more glucagon, that is what induces ketosis. And this is typically what SGLT2 does. If you see how SGLT2 typically works, of course, it does not reduce insulin. The point is that it increases the glucagon, right? It produces, flushes out the carbs, right? So increase of glucagon and increase of noradrenaline release induced by physiological stress. You have a patient with slightly deficient insulin, right? So you have, or complete insulin deficiency like a type 1, right? And beyond that, because the patient would be fasting perioperatively, or patient had some, let's say patient had vomiting, gastroenteritis, and the patient is put in a fasting state, all this typically lends to ketosis, right? Ketoacidosis, and then ultimately lands up with euglycemic ketoacidosis. Okay. Another thing is, right, also known mechanism is that SGLT2 inhibitors also produce reabsorption of ketone from the urine, right? Which is very interesting, right? So it's, it's interesting phenomena, right? So this also seems to be a added mechanism, right? Now SGLT2 we discuss, it definitely increases glucagon level. We know this from so it kind of makes that imbalance pretty good. The symptoms are very subtle. That is what makes it challenging. But you should keep your eyes and ears open, especially when you have a perioperative patient. Now, all of you, have links with hospitals. When you are seeing a perioperative patient, right, this is something which is very important to understand. When you have these subtle symptoms and when your anesthetist calls you for these issues where they are not able to resolve, this is a condition we should definitely consider, right? Sometimes the symptoms are more subtle. Patient often could have respiratory distress, could have GI disturbances, fatigue, right? In fact, just fatigue, right? Difficult to understand fatigue is also a sign of euglycemic ketoacidosis in some of these patients. So these are the conditions. We'll discuss perioperative in the next few slides as well. What is the protocol to follow? But the point is that euglycemic ketoacidosis is a condition which you need to recognize. You need to understand it. Now with increasing use of SGLT2 across the country, you are going to see patients even in smaller towns being prescribed SGLT2. Very commonly I see, right? You have to be very careful because a lot of the times in the smaller towns, the physician there may not be very well apt with euglycemic ketoacidosis. So the patient will often be referred to you, right? When the patient gets referred to you, a tertiary care center, you have to recognize them and make the diagnosis. So you should be aware of these kind of things, right? Okay. One condition which is not a label contraindication, right? And this is an area of debate, but generally I do not prescribe SGLT2 to a newly diagnosed diabetic patient with a very high HbA1c, right? For example, a patient comes to me, newly diagnosed, HbA1c of 11, right? I don't prescribe SGLT2 in the first go, right? For whatever, patient may be obese, you will tell me, the cardiologist will tell me 2 indications and the nephrologist will tell me 1 indication for prescribing it, but I'll still say no, not now, wait, right? There are multiple reasons, right? I've burned our fingers so many times that now you realize that don't give it at that time. But I write a note saying that we'll consider SGLT2 so that, the nephrologist and cardiologist does not prescribe it. They have at least thought about it, right? It's not that I have not thought about it, but not, deliberately prescribed it now, we are waiting for it, right? What happens is sometimes you have this couple of problems, right? One, sometimes in the first instance, you really don't know whether this is ketosis-prone patient, you don't know the patient's residual. A lot of these patients are young patients. You don't really know what is the residual beta cell capacity. Secondly, when you start with a very high HbA1c, right, the SGLT2 is very effective, the HbA1c comes down very rapidly, but, right, the osmotic symptoms worsen, right, the patient becomes miserable, the malaise and fatigue becomes severe, and you precipitate a genitourinary tract infection, right, even if the patient did not have, right. So when you come with sugars of 300 and 350 and 400 and you give an SGLT2, suddenly the blood sugars come down, but you precipitate a GTI, right. And the thing is about genitourinary tract infection is a lot of time I also realize that unless you specifically ask for it, the patient does not often volunteer this information also. The patient comes with 400 sugar, patient actually had genitourinary tract infection, right, but patient did not tell you that, right, and then when you prescribe it and it gets worse and then the patient goes to dermatologist or patient goes to urologist, the urologist says, kya dawa thi the? Right, where the patient already had GTI when to start off, right, and then you feel that you missed that as a diagnosis, right. So what I generally do, of course you take a history, I'm not saying you don't take this, the point is, when a newly diagnosed first time patient comes with very high sugars, I would say that don't give SGLT2, right, whatever other drugs you're giving, let the sugars come down, let the HbA1c come down to around 8, less than 8%, and then you get all the benefits of SGLT2, so you then give SGLT2, and then start pulling out some of the other drugs which you're giving, right, maybe a sulfonylurea, maybe a DPP4, whatever, right. So all this is again a trick of trade. I'm not saying that this is a published contraindication, right. There will be people who will still argue against it, but in a practical sense, this is what helps you keep your patient with you, because otherwise, patient will say, first instance of GTI, patient will go away, right. And any patient referred to me by urologist for diabetes, I don't give SGLT2 therein, right. Patient comes from urologist, no, okay. So not right now, right, we'll wait for it. So these are the things, right. A patient with ongoing catabolism, again similar to this, patient has weight loss. You take the history, a diabetic patient, newly diagnosed patient tells you that I am losing weight, right, I have significantly lost 10 kgs in the last few months, and that's why somebody said that why don't you get your sugar checked, and then they checked the sugar and it was 400. Don't give SGLT2 that time, right, because you will worsen the catabolism, again the patient becomes miserable, right. So ongoing weight loss, ongoing catabolism of any type. Sometimes you have surgical patients, sometimes you have onco patients, right, patient who is undergoing some chemotherapy, patient is undergoing some other treatment, right, and patient is already catabolic for some other reason, right, and you give an SGLT2, patient becomes more miserable, right. So it will work for sure, right, your sugars will come down and look very nice on paper, but the patient will be miserable. That is what you have to be very careful, and a miserable patient is not going to give very high gradings to you, even though their blood sugars may be normal, right. So this is the thing. This is of course needless to say, recurrent or complicated UTI, again this is something you make your patient worse. Why would you do that? Always now one standard history, if you always take is history of UTI, patient has history of complicated UTI. There will always be at some level pros and cons which also being discussed, whether there are times where you have patient with history of, vague history of UTI, but you feel that the benefits of SGLT2 far outweigh the risk. Maybe, right? Because then it's probably, life and death. Maybe it's maybe patient has heart failure and, SGLT2 is really going to work. The point is, in your routine outdoor patient with recurrent or complicated UTI, better not again burn your finger by putting an SGLT2, right? Consider other drugs and then see where you go, okay? Needless to say again, current or recurrent genitourinary tract infection, don't give, right? Patient already has GTI, don't give. Arguable thing that would you never give it? Answer is probably not, right? Blood sugars are better over a period of time. Patient doesn't have an episode of GTI for a long time, right? Patient maintains good genital hygiene. You explain the genital hygiene to them. And then at some point you feel that the benefits are definitely going to outweigh the risk. Again, I prescribe, right? One very important message, and there was a very interesting study in diabetes care some years back, where they actually looked at, a simple genital hygiene measure which can actually prevent GTI. The incidence of genital tract infection by that simple instruction became almost 80% less, right? With a simple, so they did a very simple study where in one group they gave non-specific instruction. You have to keep genital hygiene. The other group, they specifically told them what to do, right? Just by doing that, you reduce. So what basically for males, uncircumcised male, you need to ask them to retract their penile, their foreskin, and clean that part every time they pass urine, because you don't want the urine to stick there, right? A simple water cleaning, simple measure, very simple, prevents GTI by 80%. So where you need to prescribe SGLT2, you feel that the benefits, and patient has a history of genitourinary tract infection in the past, a simple hygiene measure, you just explain to them, patient will understand, right? And just by doing that, you actually reduce the risk, and then your patient, loves the medication, right? So that's the thing, right? Now, a debatable area, and it's a nuanced point, so I'll put some caveats to that. A patient with an acute injury where etiologists don't know, you don't know why the patient has acute injury, right? Patient comes for the first time, creatinine is already high, or patient has acute on chronic condition, right? Unknown unknowns, don't prescribe SGLT2. That is my suggestion, right? When you're very clear that this is chronic kidney disease, stable CKD, go ahead, right? But you don't know where this thing came from. You don't know where the creatinine suddenly shot up, right? Now, there's an interesting dynamic. I actually looked at some literature on this. There are a lot of studies where they've actually seen that if you see over a period of time, a CKD patient or a patient with diabetes on SGLT2 actually has less episodes of acute kidney injury, right? But there'll always be, like in the case number 2 in 2020, there was, or maybe some cases where you had SGLT2 triggering a acute kidney injury also, right? So it's a dynamic where you have to understand the equation, right? You have to see where the patient is. A stable CKD patient is going to benefit from your SGLT2, right? And over a period of time, we'll have less episodes of acute injury, would have good renal outcomes for a long time. I think it's a miracle drug for actually patients with diabetic CKD. But you have to be also cognizant of the fact that some of these patients you need to be careful, right? So that is the thing. Now comes the perioperative part, and this is the thing what I said. Now there's a meta-analysis which Seki did. What they wanted to see is that which are the conditions where you have more risk of developing perioperative SGLT2 inhibitor related euglycemic ketoacidosis, right? Now, type of surgery, they found that bariatric surgery was the most common type of surgery where this diagnosis was seen, right? This is there, of course, it's a meta-analysis, but there'll always be a bias, right? Because a lot of studies would have been done in, so always take it with a pinch of salt, what I'm just trying to say. But generally speaking, bariatric surgery, a lot of these patients will be diabetic, definitely on SGLT2 because they will be obese, right? So there is again, it's a GI surgery. So all these things, most patients were diagnosed in the first postoperative day, 23%, right? So again, important time, right? That again, if you keep your eyes and ears open, you will, not miss it on first postoperative. It's a good time to make a diagnosis, I would say, right? The trigger, the most, cases, the clinical symptoms were nausea, vomiting, GI symptoms which were not explained. So unexplained GI symptoms was the most common trigger, right? Some of these patients had shortness of breath, dyspnea, fatigue, malaise was observed, right? And the tests which they did, some of them use beta-hydroxybutyrate, but if it's not available, anion gap is a very useful thing, right? So anion gap more than 12. Typically the mean anion gap in these patients was 23, right? More than 12 definitely. So a lot of the time, anion gap could be a useful test to diagnose euglycemic ketoacidosis in your patients, because remember the sugars are not going to be very high, right? So you need to justify, right? And if the ketones, beta-hydroxy is not available, then perhaps, remember urine ketone may not give you the diagnosis. Remember this. This is the point, right? Because of reabsorption, right? Remember, it is going to reabsorb the ketone. So ketone bodies are going to be reabsorbed. Urine ketone may sometimes be even negative, right? So that is where you have to measure it in the blood or beta hydroxybutyrate or measure anion gap, and that's why just don't rely on urine ketones, right? So that's again a message. So what do you do in these group of patients, right? Now, first of all, you need to understand whether SGLT2 is prescribed for what reason, right? So now let's say a patient comes to you. This is a common situation. Every day, a lot of you will be seeing preoperative fitness, right? Physician fitness for surgery, right? A lot of these patients will be on SGLT2. So it's a common problem, right? I'm sure we all appreciate it's a common problem we'll all be facing. If you're not facing it, you'll be definitely facing it tomorrow, right? It's a common issue. See whether the patient has indication, what was the indication for SGLT2. Now, whether it was diabetes or whether the patient is not having diabetes. Interestingly, now there are of course reported cases in non-diabetic patients also developing euglycemic ketoacidosis, but generally speaking, a lot of these studies and from the meta-analysis and from the literature, most of the patients who had euglycemic ketoacidosis were diabetic, right? A non-diabetic patient given SGLT2 by the cardiologist or by nephrologist for some other reason, right? For HFpEF or heart failure with reduced, so it's given for heart failure, but patient is non-diabetic. Such cases probably you can go ahead with surgery, not a problem, right? Having diabetes, you need to see whether it's an emergency or elective surgery. Now, let's say it's an emergency surgery, right? What you do is ask them to get an anion gap done, right? So anion gap is more than 12 or beta hydroxybutyrate is more than 2 millimoles per liter, right? Then if it's a yes, that means patient already has euglycemic ketoacidosis. Now, would you want to subject a patient already in ketoacidosis to surgery? That's the debate you have to make with your surgeon. So you ask your surgeon, can surgery be deferred? Yes, then treat the ketoacidosis first, right? If the surgery cannot be deferred, right, then start the patient on insulin infusion with dextrose, right? Patient will be high risk for surgery, definitely, right, for sure. That has to be made aware, right? But if the beta hydroxybutyrate and other things are fine, right? So now this has become part of my routine pre-op assessments of diabetic patients, that if I see a patient on SGLT2, I ask for a beta hydroxy and anion gap, right? Emergency or elective, whatever surgery, I just ask for that, right? And if it's high, sometimes you will diagnose a euglycemic ketoacidosis, defer the surgery, you know, and help the patient in a sense. But if it's normal, you are at least assured that the patient was not in euglycemic ketoacidosis before the surgery. After that, whatever happens is a different issue, but at least before he was not there, right? Okay. If it's an elective surgery, generally the guideline, and this is what FDA also says, you stop 3 days, SGLT2 3 days before the surgery, right? Now, recently in one of the endocrine groups where you also have endocrine surgeons, there was one irate endocrine surgeon says कि सबको SGLT2 बंद करना ज़रूरी है, right? Because what happens is, remember that 3-day period we say, but I said that stopping SGLT2 is also not very easy, right? Now, 3 days prior to surgery, patient is not going to be admitted, patient will be outpatient, right? Outpatient, you stopped SGLT2. Now, what have you done in response to that? Have you started insulin? Have you started a sulfonylurea in place? Because SGLT2 is a powerful drug, right? And it's very difficult to predict what the response will be post that, right? Now, patient was having good blood sugar control, HbA1c was 6.9, right? Patient was on SGLT2 doing very well, goes to the doctor, stops the SGLT2 because guideline is 3 days prior to surgery. By the time patient lands up in surgery, blood sugar is 300. Now, what do you do then? Surgery gets cancelled, right? So you need to have a plan B, right? So if you're stopping SGLT2 3 days prior to surgery, then what are you going to do? Are you going to monitor the sugar? And if you're going to monitor the sugar, what is the response if the sugar goes high? This has to be planned, right? That's why, you know, like I said, the irate endocrine surgeon said कि सबको बंद करना क्यों ज़रूरी है, right? But that's what the guideline currently says, that 3 days prior to elective surgery you stop it, right? And if you've done that, go ahead with the surgery. No, patient suddenly lands up with SGLT2, again beta hydroxybutyrate anion gap, कर दो, right? Medico-legally also it is safe, right? So you've done this. If it's there, cancel the surgery. It's an elective surgery, cancel surgery, treat the ketoacidosis. But if it's not, then you can, you know, start the insulin with dextrose and surgery under high risk. These patients definitely require a GI drip, perioperative, right? No debate. Okay. Intraoperatively, of course, monitor the blood sugar and, you know, with dextrose containing fluids you should have, right? So this is the perioperative. And postoperatively again, as a rule, what I said is the patient who, my practice, patient who first day postoperative, if the patient is going to remain fasting, in that situation, I would again monitor the anion gap. And if the patient came and the SGLT2 was not stopped 3 days prior to surgery, in such situations, again post-operatively monitor, right? It's not a bad idea, just one extra test is not going to harm your patient, but if the patient does develop some euglycemic ketoacidosis, you can pick it up, right? So when I go in the evening rounds, I generally ask for that. I ask them to send the report to me, right? For at least my assurance that I am not, we are very sure that this has not triggered a thing, right? Obviously, patient planning for pregnancy or patient already pregnant, it's a label contraindication, there is no safety measure. Needless to say, this is actually again, these days even more common than I thought, right? A lot of the times now you're young diabetics very commonly. Also, we see a lot of patients who are going IVF treatment, right? Who are going for IVF treatment. Now, again, patient is diabetic, 38-year-old, just few days back, 38-year-old patient, diabetic on SGLT2, doing well, right? HbA1c 6.9. But now they are planning to start the next IVF cycle. What do? Stop SGLT2, right? That's the best, put the patient on insulin. Again, you don't want that the patient gets pregnant and then patient was on SGLT2 where you don't know what's going to happen, right? So always better to plan these things out. Talk to your gynecologists also, talk to your IVF people also. Diabetes and CKD, I'm not saying it's a contraindication, right? What I'm saying is these are nuanced points you have to understand. Now current guideline says, and this, Maureen will discuss in more detail, just to tell you from my end, SGLT2 can be initiated up to eGFR of 20. Drug can be continued in type 2 patients if the eGFR falls also below this level. This is the current recommendation from the KDIGO guideline, right? And the major consideration where you should stop only when the patient undergoes dialysis, right? Till then you can actually continue SGLT2 because again the benefits far outweigh the risk, okay? Rest we'll discuss in the thing, right? These are the published list of contraindications as per the documents. Type 1, renal impairment or chronic kidney disease with eGFR of 30. I don't know if there's no label update so far, right? This label still say 30, but guidelines have now moved to 20 because of the newer studies. History of diabetic ketoacidosis, exactly what I told you. Pregnancy and breastfeeding, severe UTI or history of severe UTI, hypersensitivity and patients on dialysis. These are all published contraindications to SGLT2 inhibitors, and these cases you have to be very careful and not give it, right? So I thank you and to the next meeting. Sure.